Hello, everyone. On behalf of Ford Richardson, we'd like to thank you for joining our webinar, Validity Assessment in Cases of Claimed Brain Injury. And without further ado, I would like to pass it to Scott Ford.
Thank you, John. We've been wanting to do this presentation for a good while, and I'm really excited to have a panel with both Dr. Zasler and Dr. Bender, two national experts in the area of brain injury. So I'm going to confine my remarks to about 10 minutes or less, just to talk about some of the legal implications of why brain injury, that issue is important in the context of workers' compensation. But before I get started, let me just briefly introduce both Dr. Zasler and Dr. Bender. As I indicated, they both are well-renowned national experts. Dr. Zasler is board certified in the area of physical medicine and rehabilitation. He has specialized in the treatment of brain injuries well in excess of 30 years. I think many of you will know him as a frequent lecturer and author in this topic. He has led the Concussive Care Center in Virginia since 1992, and he's a graduate of the Chicago Medical School. Dr. Bender is a board certified neuropsychologist. He's an associate professor of psychiatry and neurobehavioral science at the University of Virginia School of Medicine. He earned his PhD at the University of North Texas. He interned in clinical neuropsychology at Yale. He also is a frequent lecturer, author, and trial expert. He often is asked to serve in a role of expert at trials, predominantly, as I understand it, in the area of brain injury and PTSD. So again, I want to thank both physicians for agreeing to be on this panel. The area of brain injury is a significant issue of importance with workers' compensation. NCCI, that compiles data, has indicated that 17% of mega claims are defined as those that have an exposure that exceeds $3 million. 17% of those involve some aspect of a brain or head injury. Also, and that's a fairly recent statistic from 2021. For the period from 2013 through 2018, NCCI has reported that the total spend for workers' compensation claims that have a head or brain injury component are more than double the average lost time claim. So those that, and we've got a big group of them here. And John said, if you have questions, put them in the chat box or the Q&A at the end of the comments. We'll take those. But Ross, if you could put my PowerPoint up on the slide, the participants. All right, next slide. All right, so the common path to compensability for a work comp case in brain injury is generally either as an injury by accident or we see it as a compensable consequence. So an injury by accident is, just as it sounds, typically what you see is that it's a direct trauma to the head, but sometimes we see them in the context of compensable consequence as well. And there are two cases that are cited here that stand for that proposition and are examples of brain injury becoming a workers' compensation case as a compensable consequence. Daniel Construction was a brain injury where the claimant was awarded permanent total benefits as a result of PTSD. Johnson versus Paul Johnson Plastering, a Virginia Supreme Court case, stands for the proposition that depression can form the basis also for a brain injury a case in Virginia. All right, next slide. Permanent total is the exception in Virginia that limits benefits to 500 weeks. In Virginia, there is a cap for all cases for 500 weeks, and that's set by statute at 65.2518 of our code. The exception is permanent and total when it's established under 503. And as it relates to this topic, brain injury, in order to be eligible for permanent total status, the injury to the brain must be so severe as to render the employee permanently unemployable in gainful employment. And that obviously requires an expert opinion. More often than not, it would come from somebody like Dr. Bender or Dr. Zasler. Very quickly, let's touch on statute of limitations. Next slide. All right, so in order to bring a claim, the claimant has to bring these claims within 2 years. That's under 601 of the code. With respect to bringing a compensable consequence claim forward, there is no limitation. There have been attempts to challenge that from time to time in Virginia. They have all not succeeded. There is no time limitation for bringing a compensable consequence claim for the medical portion. Now, on the wage loss portion, it has to be brought within 2 years from the date benefits were last paid, and that's governed by 65.2708. Very quickly, some red flags. Next slide. That I'd point out. If you're handling a brain injury case, reasons from at least my perspective, a defense perspective, where you may want to question whether you truly have a valid brain injury case. Number one, was there actual physical trauma to the head? If there has not been any, you may want to question whether you truly have a legitimate claim for brain injury. Next is no loss of consciousness. While not necessarily determinative, the absence of the same should be closely examined. And I'm sure the physicians will talk about the Glasgow Coma Scale. Scores of 15 or 14 may create the basis to question as well. You'll see those typically in the initial reports. Possible head trauma that has occurred after the accident. If you have that, you may have an opportunity to challenge causation. Of course, pre-existing brain injury, another basis where you could have an opportunity to challenge causation. Physician involvement on claims where bogus brain injury claims are often asserted. And the last item there is normal diagnostics of the brain. Typically, you see those in MRIs and CTs. The next few slides, I'm just going to leave in there for your information purposes only. These are issues to cover in a reported statement. Again, from my perspective, doing defense work for almost over 27 years at this point, but things that I would suggest that the adjusters really explore. And Ross, if you want to just page through, there's 2 more, and I'll just leave that in your material for your reference. All right, last slide, if you could advance to the last slide. All right, how do you combat claims for permanent total brain injury? A few pointers, again, from my perspective. One, the best path to dispute a claim for permanent total is a clear statement from the treating doctor that the claimant does not have brain injury that's so severe as to render them permanently unemployable. Be mindful that the opinion from the treating physician will be afforded great weight in Virginia. That's the statement of law, and that's what the commission applies in every case that they have. If you see a potential claim where you might see one coming as the adjuster on a file, it's important early on to secure light duty work if you can, and encourage offers of light duty work from the pre-injury employer, which often are those in the best seat to make that happen. If you see that you might be looking at a potential perm total case, you don't want to wait until you get near the end of the 500 weeks to start trying to develop the fact that the person can actually work. Surveillance in these cases is often quite useful. IMEs might be needed. And if you get an IME, the purpose would be to attempt to secure an opinion that has not been severe brain injury, such that the person's precluded from the ability to engage in gainful work. Neuropsychological testing is often very helpful for a good IME. MRIs or CTs are often very helpful. It's important to note, and this is often overlooked, that the IME physicians can order testing as part of their evaluations. And again, testing, it has to be non-invasive, but non-invasive testing like neuropsychological evaluation or reviewing, pen and pencil tests or MRIs or CTs are all fair and appropriate, and a good IME should employ that. And then finally, my last comment, vocational rehabilitation experts may be needed. We often use these folks at hearings to provide opinions that the person is capable of gainful employment. So hopefully I kept to my time limit. and I want to save the majority of the time for the experts. So I'm going to turn it over now to Dr. Scott Bender.
No, I think you're going to turn it over to me.
I'm sorry, Dr. Zasler. Yes, you're correct.
No problem. Attorney Ford, if we can come back to your comment, because I think there'd be mixed opinions about ordering tests outside of the confines of the actual medical legal evaluation, such as an MR. We can discuss that in the Q&A, because I'd like to make a comment on that. Next slide, please. So some educational objectives that Dr. Bender and I have put forward for this talk are to review some basics. This basically came out of a request from Attorney Ford and his staff. Understand the importance of validity assessment in cases of claimed acquired brain injury, or ABI, associated impairment and disability. Examine the role of validity testing in interpreting clinical and forensic presentations relative to effort, response bias, as well as performance and symptom validity in medical and psychological assessments. And we'll talk about some of these terms if you're not familiar with them already. Next. We'll also delineate techniques in general terms used to assess validity of claimed cognitive and behavioral impairments, provide some insights into neurological physical exam as related to validity assessment. That would be more in my bailiwick, the latter one. Next. Don't get ahead of me. I didn't say next yet. Traumatic brain injury is a form of acquired brain injury, which can occur when a sudden trauma causes damage to the brain. It's important to understand that you don't need to have direct impact to the head, that brain injury can occur with the head being whipped, as might occur in whiplash, without direct contact to the cranium or head itself. You can also have it, obviously, with direct impact injuries, but just because you have direct impact doesn't mean you had a brain injury. So you can have a head injury, and please use those terms separately, without having a brain injury, or you can have both together. You can also have what are termed penetrating brain injuries, like if a bolt somehow got shot into your head and damaged your brain, but that's a much more localized or focal brain injury, not the diffuse kind of brain injury that we typically see with trauma, particularly at higher speeds. And brain injury can occur with both acceleration and deceleration injury. So you can go from 60 miles an hour to 0, or you can get a brain injury from all of a sudden accelerating too fast, and your brain basically sloshes in the other direction. Symptoms of TBI can be mild, moderate, or severe, depending on the extent of the damage to the brain. A normal scan is a good thing, but it doesn't rule out brain injury. All tests have thresholds of sensitivity and specificity that need to be understood by the clinicians, whether a neuropsychologist or a physician. So I think it's important to note that even in concussion cases, a normal scan doesn't rule out a brain injury. Next. Concussion, a few facts. A person with a mild TBI or concussion may remain conscious or may experience a loss of consciousness for a few seconds or minutes. Generally, a mild brain injury is defined as an LOC, or loss of consciousness, no greater than 20 minutes. Other symptoms of concussion may include headache, dazing, confusion, dizziness, among a constellation of symptoms, but there is no consistency. So one person may have headache and cognitive issues. Another person may have buzzing in the ear or tinnitus and fatigue and sleep difficulties. Next. Moderate to severe TBI, which you're not going to see as often. 85–90% of all injuries are mild, that is concussions. A person with a more severe injury of a moderate to severe nature may have variable outcomes from death to even good outcomes. So even with the worst Glasgow Coma Scale score of 3, you can still have a good outcome and return to work, as an example. Is that common? No, but does it happen? Yes. Long-term cognitive, behavioral, and physical impairments are common in this group of patients. Neurologic recovery can occur over a multi-year period. So this isn't something where you can say someone is likely at neurologic MMI after a year. Most cases of moderate to severe TBI demonstrate continued recovery over at least a 2 to 3 year period. Appropriate and timely neurorehabilitation and neuromedical care improve functional outcomes. Next. Some post-concussive caveats. I have for 20 plus years said don't use the term post-concussion syndrome because a true syndrome really does not exist if you understand what a syndrome is, which is a consistent set of findings associated with a condition with symptom linkage and coupling of symptom resolution. There's no consistency to the signs or symptoms of concussion, as I just stated. There is also no symptom or set of symptoms that are a priori diagnostic of concussive brain injury. The other thing I would note is that the incidence of the symptoms that are associated with concussion are also quite frequent in the general population. So they're not specific to concussion. Terms such as PCS and PPCS are used, and we'll talk more about that both in Dr. Bender's lecture and mine. Post-concussion syndrome used to be PCS, but we now use the phrase post-concussive symptoms and persistent post-concussive symptoms and avoid the syndromal designation. I'll talk more about the persistent, as will Dr. Bender. Next. What's the natural history of concussive brain injury? Neurologic and functional outcome of uncomplicated concussion is generally very good. Uncomplicated refers to those patients with normal acute imaging. Most clinically recover within 90 days. Recent work suggests that physiological dysfunction tends to last longer than clinical measures of recovery. It is currently not possible to define a single time window for recovery as far as physiological recovery. There's still debate regarding how to segregate symptoms to confirm that they are in fact post-concussive versus due to other things like cranial trauma, psychological consequences of injury, other injuries like whiplash, which can present with, interestingly, a lot of the same symptoms as can concussion. Next. The so-called miserable minority, not a term I came up with, someone else came up with that one, are those who have persistent symptoms, which the cause remains debated and we'll address further. Greater age, higher level of education, and male gender tend to do better. High school athletes, particularly girls, at greatest risk for persistent symptoms. And there are reasons for that. We may not have time to get into it, but if people are interested, happy to discuss offline. Chronic problems, generally not due to the brain injury itself, 5% or less may have concussion-related long-term problems. That is greater than a year. Next. Important information to gauge risk. Scott kind of got into this. Mechanism of injury risk factors. So if you're in a vehicle accident where you get hit at 10 miles per hour, that's a very different injury than getting hit at 80 miles an hour. So things like that are important to understand in the context of assessing risk for TBI in any given injury. Was there a loss of consciousness? If so, for how long? Was there dazing or confusion? What was the GCS score? Again, a score of 15 is a good thing if you're trying to defend a case, but it doesn't mean there's absolutely no risk of brain injury. Any drug or illicit substances on board, make sure you're looking at labs to assess whether toxicology screens were done. Typically, they're done in any major trauma, not necessarily in fender benders. Acute symptom complaints. What did the patient complain of in the emergency room, and how did those complaints change over time? What were the acute neurological findings? What were there any, or was the neurologic exam totally normal? Was there a history of direct head impact and or facial skull fractures? If you have facial skull fractures, it implies much more significant forces and increases risk of brain injury. Next. Record red flags, poor records with incomplete documentation can be problematic for you if you're trying to defend a case. Complaints that are delayed in onset raise a red flag because most complaints should be highest in terms of the magnitude of the complaint early after the injury and tend to lessen over time, not all of a sudden appear a week, 2 weeks, 2 months after the injury and get worse over time. Story changes over time, injury described as worse. You look in the EMS report and it says, patient says no loss of consciousness. In the ER, they say I was out briefly. And then by the time they see me or Scott for an IME, they say they were out for 30 minutes or 40 minutes. Those kind of things are worrisome. Complaints don't make sense for the injury as reported. Exam findings are inconsistent with the nature of the injury and or test findings. So someone who complains of smell loss after a severe injury, again, that's something that you could see. Someone who complains of having seizures after a concussion, that's highly unusual. Or if they complain of having paralysis on one side and they have a normal scan, that smacks of either conversion disorder, what used to be called hysteria, now called functional neurologic symptom disorder, or faking. Prior work comp injuries, litigation, or fraud claims all increase risk of red flag and malingering, or at least symptom exaggeration, and prior psychological problems or abuse/trauma also are red flags that increase vulnerability to psychological problems after these kinds of injuries that often get misinterpreted as brain injury. Next. What to think about in the context of validity assessment. When we see these patients, both clinically and forensically, obviously brain injury is in the diagnostic mix of things we need to consider, but there's a whole litany of other diagnoses that can often present with similar/parallel symptoms to brain injury: depression, chronic pain, anxiety spectrum disorders, functional neurologic symptom disorder. Again, that's current term for hysteria. Feigned disorders, which there's 2 main types, and Dr. Bender, I think, will address some of this later. Factitious disorder and malingering. Hypochondriasis, misattribution biases, where someone misattributes their problems to the injury, but they're not related to the injury. Nocebo effects. This is a problem in both clinical and research arenas. If you tell somebody they had a brain injury, there's a much, and how you tell them they had a brain injury, there's a much higher chance that they may assume certain behaviors that they wouldn't have, just as when you refer someone as a clinician to another clinician and you tell them up front what they're expected to find. So if I send a patient to Dr. Bender and I give him a detailed history and physical and say, I think this person had a concussion, then the expectancy on the part of the person I'm sending the patient to is that, hey, I need to find a brain injury. So that can lead to negative consequences, kind of the opposite spin of what placebo implies. Nocebo is negative consequences of information provided. Good old days bias is another concept that Grant Iverson has discussed. I'll stop there on this one. Next. So sometimes clinicians are left scratching their heads as far as what the heck is going on. Next. What tests provide 100% proof of malingering? Well, there is no test that exists that provides such information. The diagnosis is made based on analysis of myriad data points based on record review, patient history, and exam. Clinicians have been sued, interestingly, for slander for labeling someone as a malingerer. And there's often reticence on the part of clinicians who do medical legal evals to label someone as a malingerer. We can talk about that further in the Q&A. You have to be extremely careful in terms of the analysis before making a claim that a claimant is feigning their impairments. must differentiate exaggeration, which can be conscious or unconscious, from functional neurologic symptom disorders, factitious disorder, and malingering. Issues in the last few years, which will be discussed further, with exclusion of opinions on claimants' truthfulness. So the court has become very plaintiff-oriented in this context in terms of having plaintiff attorneys kind of limit what we can say about the patient or claimant in the context of these medical legal evaluations, and even beyond that in terms of telling us what we can and cannot do, how long we can do it for, and what specific tests we can give or not give. Next. There are only two ways to know if someone is feigning. The claimant tells you so, and second, there is evidence of the claimant doing something they claim they cannot do, such as video surveillance. Even in the latter scenario, you can only comment on that particular finding, not the totality of the presentation. So if the patient says, I always walked hunched over like this, and you see them out dancing in a surveillance video and they're not hunched over, then you know that's not organic and accurate reporting, but you can't say the patient doesn't have cognitive impairment because they're not hunched over, as one example. Next. So how do we analyze validity in the context of neurological findings after an acquired brain injury? You have to know the disease you're assessing, as well as what you are not treating, know the common and uncommon aspects of the condition, understand time of symptom and sign onset. Symptom is what the patient reports. Sign is what I find on neurologic or physical exam. Know how to assess for validity, effort, and response bias. Request and review records. That's really critical. And I think when you see forensic exams where people haven't requested pre-injury records or the complete post-injury file, they're giving themselves a potentially big gap in terms of information processing that just shows they're not really doing their job well. Know how to listen, observe, and examine. Next. Interview evidence. Look at the temporal relationship of signs or symptoms to the injury. Assess for report of non-organic symptoms. Those are symptoms that are unlikely, absurd, or overly specific, frequent, or severe, given the context of the injury. Consider inconsistent reporting across time and/or clinicians, as I mentioned earlier. Be concerned when there are disparate corroboratory interviews, which I always encourage. I don't always get allowed to do them, particularly when I'm doing a defense exam. When I'm doing a plaintiff exam, I always get to do them. The clinician who treats a patient always gets to do them. I think it seems unfair that in a defense context, you're limited from sometimes doing corroboratory evals when you ask for them. Next. Engagement and effort. In the context of assuring a valid exam, you have to make sure that the claimant is putting forth full effort and is engaged in the assessment process. Therefore, it's important to emphasize the need to the claimant to provide full effort. When it is apparent that full effort is not being provided, the examinee should be challenged in a non-confrontative manner. Maintaining engagement may require verbal encouragement and/or breaks if there are complaints of fatigue. Next. Why is assessment of effort important? Without satisfactory effort, any ability test, whether the neuropsychologist does it, whether I do it, whomever, speech therapist, is going to yield invalid reflections of a person's true capacity. Poor effort on testing and exaggeration of symptoms as well as signs are more common in persons with secondary gain incentives. So there's good literature here to show that people who have work comp cases, Social Security disability, personal injury cases have a greater propensity to symptom magnify. Next. Reasons to test for effort. Poor effort during testing is common. There's lots of literature on this. Poor effort has a major negative impact on neuropsychological test results. The effect of poor effort dwarfs the effect of concussion or other conditions that have modest effects on cognitive functioning. Next. reasons to test for effort. It's considered standard practice in forensic psychology and neuropsychology to do so, as well as response bias measures. The same should be said for and occur in other aspects of clinical practice, as well as outcomes research. Physicians, though, and certainly therapists, are typically not trained and don't do those type of tests in the context of their own assessments, and I think that's a mistake. Next. What causes suboptimal effort? This is highly controversial, and maybe we can get into this, Dr. Bender, in the Q&A. There have been debates in the literature. Paul Green, who has since passed away, who was a very well-known neuropsychologist, and why am I blanking? Aaron Bigler had a big debate about this in the neuropsych literature about effort testing and the things that could or couldn't affect results on effort testing. And all these things were brought up that could cause suboptimal effort. It remains controversial about just how much these things can affect performance. So there are still controversies here, and it's important to acknowledge that. Next. Response biases and validity assessment. Response biases may be positive or negative. Context will drive a lot of the direction. So if you had no response bias, you'd be responding right down the middle. That's the way you want people to respond, whether you're an adjuster, an examiner, a lawyer, you want them to tell it like it is. If you underreport, there are reasons for that. So people like athletes, people like firemen and policemen, because they want to go back to the job and they see themselves in that position as and any change in that would be a significant narcissistic insult. They all tend to minimize their symptoms, whereas people involved in work comp, litigation, personal injury, as a group tend to have a much higher lean in terms of response bias the other direction in terms of symptom magnification as opposed to symptom reduction. Without valid response bias measures integrated into evaluations and or research, there's no way to make a determination if the reporting of symptoms are valid. Next. So validity assessment in the neurological exam, it's important to understand the nuances involved in thorough neurologic physical exam. And I'm not going to get overly medical. I actually had a bunch of slides that I took out, but there are general as well as specific approaches to assessing the validity of neurologic exam findings. It's critical to differentiate what are called pseudo-neurological, meaning they look neurological, but they have some other explanation, findings from brain injury related neurological signs and symptoms, as well as from non-organic impairments. Those are ones that are exaggerated or feigned. Next. The utility of the entire evaluation depends on the validity of the claimant's performance and symptoms. So we now have a number of tools available to us, whether physician or neuropsychologists, and assuming you're trained to administer these, for looking at both performance validity, that is how you do on a test, versus symptom validity, which is how you're reporting your symptoms and how valid that symptom reporting is. There's a list there. I won't get into describing each of those tests, but just so you know that there are many tests now available that tap those two types of validity. Next. Caveats on neurologic exam. Abnormal neurologic exam findings may be organic, non-organic, or a combination. Psychogenic disorders coexist with neurologic disorders in up to 60% of patients. That may sound surprising, but it's true. Must rule out underlying neurologic disorder before labeling a presentation as psychogenic. Functional or medically unexplained symptoms account for about 1/3 of all new referrals to neurology outpatient clinics. Next. So when someone comes to you and complains of quadruple vision, that's not something you typically see after a brain injury, and a good clinician would know that and be suspicious that there was something else going on. Next. Caveats for neuroassessment: understand common and uncommon symptoms associated with brain injury. So the common ones are easy. The uncommon ones are where the challenge comes in. So can you see seizures or movement disorders after a concussion? You can, but they have a very low incidence as an example. Understand common and uncommon signs associated with brain injury. Again, that's signs are what you see on exam, the physical or neural part of the exam. Do not assume that an atypical presentation or one never seen before is necessarily non-neurological. If it does not look neurological, think about functional disorders, exaggeration, or feigning of impairment. Next. Know what neurological signs and symptoms are expected to go together. Know what to expect before the exam by looking at diagnostic testing and records. For example, I always ask to look at the hard copy of imaging, not just the report. Understand techniques that can be utilized to assess for symptom and sign validity. Educate the patient or examinee prior to testing that they should be honest and do their best. Next. Factors to consider in neurologic exam validity assessment: prior history of functional complaints, history of fraud, prior work comp cases or criminal actions. Is there a model for illness? Prior mental health issues, recent stressors, incentives for illness behavior, prior trauma and illness beliefs. Next. Understand the correlations between exam findings and neurodiagnostic findings, including imaging, electrophysiological testing like EMG, nerve conduction studies, excuse me, neuropsych testing. For example, if someone has a paralysis on one side of the body, you expect to see something abnormal on that MRI scan or CT scan. In the absence of anything, you worry that that's either a functional disorder or a feigned disorder. Understand the correlation between prior evaluations by physicians and non-physicians alike and the current neurologic exam findings. Next. I'm coming to an end here, hopefully. Caveats in neuroexam validity assessment include findings potentially being solely neurologic, solely functional, neurologic and exaggerated, neurologic and suppressed. So there's actually certain conditions where the patient can hide their impairment, functional and exaggerated or feigned. Next. And we're going to switch over to Dr. Bender.
Before we move away, if you could, you would entertain some questions, and some have come in already. One was, what do you mean by psychogenic disorders? If you could elaborate on what that means, as well as perhaps give some tips to the adjuster on how they can identify when they have that situation.
Sure. And Dr. Bender can also comment on this, I'm sure. So psychogenic disorders are things that have a psychologic or psychiatric basis and are not neurogenic or neurologic in origin. And clearly you can have a combination of those two in the same patient. So for example, a person who's catastrophizing about their injury and exaggerates because they're basically having a so-called cry for help. You may have seen that phrase. That would be considered a psychogenic issue. Somebody who has a factitious disorder, that would be considered psychogenic. It's a psychiatric diagnosis. So they feign for purposes of, it's a primary gain issue. They feign because they get something positive out of being reinforced as a patient, as opposed to the malingerer who's feigning for secondary gain, whether that's financial, not having to work, or whatever reason. Dr. Bender, do you have additional comments? I was trying to be brief.
No, I think you wrapped it up very nicely, and very good summary too of so many moving parts in your summary before your entire lecture. I think with the psychogenic, you've wrapped it up. Really, we're talking about psychological causes. That's really what it means. And the reason it's so relevant is that they can look just like neurogenic things, at least on the surface. So that's part of our process, is try to figure out what the cause is, so we can make sense of what to call it and what to do about it.
I will say, Attorney Ford, I will say that there are certain patients that you don't see as commonly, like the functional disorder patients. I think, again, those tend to be rare, but they need to be identified when they do present to a clinician. I can tell you I've seen a number of these folks over the years, and because of my practice, I've probably seen more than most, but who were treated for years as a brain injured person when in fact they had a psychiatric problem and were not getting the treatment that they needed. So not surprisingly, they didn't get better. And as soon as I walk in the door and see the patient after I've reviewed their scans and I see how they're presenting, and I listen to their speech, which is one of the hallmarks of more severe functional disorders. It's a very characteristic speech impediment. I made the diagnosis, but those are exceptions, but they need to be recognized as such when they're seen, so they're not misdiagnosed. And you see a patient with concussion who's told they're brain injured when in fact they're not brain injured. So it works both ways. There are patients who get misdiagnosed as not having a brain injury, and there are patients who get misdiagnosed as having one when they don't. Not a positive thing for the patient, but it happens.
Which Nathan gets at this next question that someone asked about, what do you mean by illness beliefs? That's what you're talking about, right? That what you believe about what your symptoms are and mean and imply, that can be very, very significant, affects the presentation. There's a lot of research in psychology on this in a variety of ways, just how important beliefs are generally. But when these folks are seen in a forensic context and are led to believe either by others or by themselves that something is true about their condition that actually isn't true, it can have really significant implications for the presentation.
There was a Harris poll a number of years back that looked at what the general public's beliefs were about concussion, and most people have very negative perceptions about what happens to you after an injury like this, in terms of the permanency of the problems, the fact that you can't do anything to get better. So that also has that nocebo effect that we talked about earlier in terms of impacting how people recover if they have already these preconceived negative conceptions about what happens to people after concussion.
One last question, and I think we'll turn it over to Dr. Bender, and again, encourage folks to ask their questions, and hopefully we'll have some time at the end. We can do this again. But one, Dr. Zasler, you mentioned, once you've looked at the scans, going in and seeing the patient, one of the folks in the audience had asked the question, they had a normal MRI and CT. Does that matter? And so I wanted you to comment on, what are you looking for in an MRI of the brain and a CT of the brain to rule in or rule out a brain injury, number one, and then number two, and I know I mentioned this to you prior to this presentation because I've had some comments from folks. Are there objective studies or testing that are out there? And the one that I mentioned to you was a study of eye movement. Is that a legitimate objective testing?
So there are now several different devices, neurotechnologies that look at eye movements. I'm going to tell you that I think it is very interesting technology. I don't think I'm ready to say that if you have a normal test that you rule out a brain injury, because you can have brain injuries that don't affect the pathways associated with eye movements and still have a brain injury but have a normal test. So right eye is one of the ones that I think you were probably referencing. The neurooptometrist that I work with in my concussion clinic, Dr. Jacqueline Thies, if you have questions on that, I would recommend that people reach out to her. She's probably the top neurooptometrist in the Commonwealth. And we use those technologies in the clinic, but again, that would be my answer to that. As far as scans, it's important to know how a scan was done as far as how much utility it's going to offer. So an MRI that's not done with FLAIR imaging or T1 and T2 imaging or diffusion tensor imaging. There's all different kinds of techniques that are used, would be of limited value as opposed to a test that was done, what's called the trauma series, where you do all these tests that look for different aspects of brain injury. So if people have more specific questions about that, I'm happy to respond by email or set up a time to talk about specific cases.
All right, very good. Well, thank you. I think, why don't we go ahead and move over to Dr. Bender?
Thank you. Thanks again for doing this talk. This is interesting stuff, certainly to me. And thanks again, Dr. Zasler, for a great review. There's so many moving parts in this area. I'm going to focus on this thing that we used to call PCS that Dr. Zasler was talking about. And for good reason, we shouldn't be referring to it as a syndrome. Yet you'll see it again and again and again in the literature and in records that you're reviewing. And then I'll move on to malingering and the formal definition, how we differentiate it from other conditions. There's lots to go through here. And again, if you have questions, happy to address them at the end. No, there's a number of ways to define what a concussion is. I think pretty much anybody who studies this would agree a concussion is a brain injury, but it's a pretty unique and specific type of brain injury. And by that, I mean, it typically doesn't involve structural changes to the brain tissue. It involves chemical changes. There's a physiology disruption that's part of this injury. And because of that, that's a brain injury. But recoveries tend to be very different in concussion than they are from moderate and severe TBI. One of the most common definitions you'll see is not pretty dated, but it's pretty good. There's problems with the definition, but I don't think they're unique. Those problems are unique to this definition. But basically, if there's any alteration in mental state or consciousness at the time of trauma, or you do get knocked out, but it's for less than 10 minutes, or you can't remember what happened immediately before or after the trauma, or if you show focal neurologic deficits. Any of those things could qualify as a concussion. And this is according to the American Congress of Rehab Medicine. A Glasgow Coma Scale score of 13 to 15 is what we consider to be evidence of a mild TPI. People have tried to narrow it down even farther and try to figure out if there's a difference between a 13, a 14, and 15. And most of those efforts have failed. Yet, I think anecdotally and clinically, you will find examiners who think that there is a difference, at least in some people. And as Dr. Zasler mentioned, a 15 is the highest you can get, but it doesn't mean you didn't have a concussion. So he also mentioned complicated mild TBI, so I don't think we need to get into that again. But the bottom line for me about this slide is that really all you need is any alteration in mental state. I can see why that's part of the definition or central to the definition, but it's also a major problem because there's other causes of alterations of consciousness. Pain can certainly be distracting and alter your consciousness at the time. Just being in shock about something, so like an accident, a car accident, for example, something that happened so quickly and it's a fairly profound disruption of what was happening right before that, wouldn't be surprising if you had an alteration of some kind. So we're left with the situation where we really don't know if a concussion occurred, and yet there's really not a better definition yet. So we're kind of in this middle ground. At the end of the day, though, it is critical to get information at the time of the event, not later. No matter what those symptoms might be later, those won't be as useful when trying to establish whether or not the injury occurred in the beginning. Next slide, please. So here's this syndrome thing that really isn't a syndrome, but we've thought of it that way for a while. So you'll see it in records all over the place. So these are symptoms on the left there, you can see in the table 1 there, most people will group the types of symptoms that you'll see after a concussion into 3: physical symptoms, behavioral / emotional, and cognitive. But within each of those groups, there's many, many things that can show up. So you can see right away, any one of those could be characteristic of concussion. Any combination of those could be indicative of concussion. There's no formula. So right away, the discerning attendee here is thinking, well, wow, there's a lot of ways this can look. Is this one syndrome? Well, no, right? That's what we're trying to impart here. When these symptoms, when any of these symptoms persist more than 3 months, we think of it as a persisting injury. And then we start to think about different factors that would be responsible for the symptoms persisting. We can move to the next slide. This is just, there's a couple studies, there's a number of them now, but here's some, these are good studies that show what we're talking about when we talk about the non-specificity of symptoms when it comes to post-concussion, quote unquote, syndrome. One study found that 9 out of 10 concussed participants in a study met criteria for what we call somatic symptom disorder now, but only a third of that same group actually met the criteria for a post-concussive syndrome. So that, again, raises a lot of red flags about what we're actually talking about here. There is a large body of research showing that cognition can be impaired right after the accident or the injury, but the neuropsychological results will return to baseline usually within 3 months. Probably the most important issue on this slide to think about is that when those scores don't return to baseline, there's a high likelihood it's not because of an injury to the brain, but due to a number of other things. And Dr. Zasler raised a number of them already. And I'll talk about a little bit those in a little bit more detail on subsequent slides. Next slide, please. So the cause, what causes post-concussive symptoms? Well, a lot of possible things. And like I just said, there's agreement that early on after the accident, primarily at least, there's a neurologic explanation, at least likely to be one, but probably not for more than a couple of months afterwards. Now, this can be quite vexing to the patient, where they don't know that this thing happens, that the physiology changes, that their symptoms are no longer really readily attributable to a neurologic event, yet they're symptomatic still. So to them, they don't know that there's been a change. Yet there's a lot of research on this. And when you do the examination, you often see these things more clearly than the patient does, or even the family. But at the end of the day, there is a complex interaction here that needs to be treated comprehensively, in my opinion, for sure. Next slide. All right, I have a case example here. I was wondering about time, but I think we should be okay. This is just kind of to illustrate what is a common scenario. Not, well, it's been a while now. I was about to say not long ago. Time flies. So this, a while ago, I saw this gentleman who was 60 at the time. He was in a car accident when he was in his pickup truck at the top of his driveway, there to pick up the mail, when a UPS truck hit him hard enough to twirl his truck around twice, probably. He thinks it was twice. EMS is called. His family calls EMS from the house. When they get there, they note that he couldn't let go of the steering wheel. He was gripping it so tightly, couldn't or wouldn't let go of the steering wheel for a few minutes. They described him as stunned, and he was repeating himself. He kept saying, "I heard an explosion. I heard an explosion." But when they asked him who he was, where he was, what had happened, things like that, he was able to answer those questions. He said he had couldn't remember exactly what had happened, though, with regard to having been hit by a truck. So it looked like that there was post-traumatic amnesia, brief period, certainly less than 30 minutes. They take him to the ED, where his CT is negative for acute changes, and he's diagnosed with a concussion there. Next slide, please. So in the ED, he complains of headache, neck pain, and tinnitus, or ringing in his ears. There's lots and lots of records in this particular case, but about 3 months later, his complaints have evolved, and they now involved insomnia, a motor tic, which was a facial tic, profound memory loss, according to his report, at least, and blurry vision. And you know, these symptoms are sort of important in and of themselves, but the timing of their onset is very important when it comes to talking about what is likely to be associated with an injury to the brain and what's not likely to be. So there's multiple referrals made, and at this point in his care, he's on lots of medications and different versions. His symptoms fluctuate a lot over the next several months. He ends up stopping his medication because he's worried about side effects. It's not clear that he's having any side effects, but he's very worried about them. So he stops them. He then gets diagnosed with PCS, with post-concussion syndrome, about 5 months afterwards. And then he files suit right after that. Next slide, please. And we'll come back to him later. So here's a graph that I like, or that is more of a table of diagnostic challenges regarding this thing, this post-concussive syndrome, for lack of a better word. It's fairly busy, but the vertical axis is the percentage of times that various groups endorsed symptoms consistent with concussion as defined by the International Classification of Diseases, the ICD-10. And the horizontal axis is the group, right? What group we're talking about. And then we're looking at boys and girls in high school. These are athletes. So the main picture here that we're seeing is that even in adolescents, athletes that are adolescents who have never had a concussion, they're endorsing symptoms that would meet criteria for concussion and a concussive disorder. This is one way to illustrate the non-specificity of these conditions. So if you look, for example, let's look at ADHD. You can see ADHD there. It's the fourth from the left. Over 50% of girls with ADHD will actually meet diagnostic criteria for a concussion or a post-concussive disorder of some kind. About a third of boys will. You can see if they were in substance abuse treatment at any time, an extremely high number will meet diagnostic criteria for a concussive disorder, even though they've never had that. So it's just, one of these things where we're seeing this in a number of ways. And I have a couple other slides that'll show that too. So we can move to the next slide. Here are some percentages of symptoms that are endorsed by just people in the general population. These are healthy people not presenting for any complaints or symptoms who will report these symptoms though when asked. So if you give a survey of these symptoms, these symptoms are considered very much consistent with concussion. These are associated with concussion and post-concussive disorders and symptoms. You can see a lot of the general population will endorse these symptoms. So again, we've got some problems to figure out, like what are we actually looking at when we see these symptoms? Next slide, please. So this is another table that shows a related concept. It's a little bit different. These are effect sizes. So on the vertical axis, you see effect sizes. And an effect size is basically a statistic that shows how different the performance on a given measure was between two groups. So a moderately large effect size is usually considered between 0.5, 0.6. There's sort of a disagreement on where we should start calling that, but anything above that would be considered large. 0.7, 0.8, those are getting to be very large effect sizes. So the take-home message here is that you're seeing different groups at the bottom. And again, the effect size on the vertical axis, if you go all the way to the right side, that last column that says MTBI rolling it out, that is a meta-analysis of mild TBI studies, and found that the effect size of a large number of TBI studies looking at mild TBI showed the effect size to be about a negative 0.07 when compared to healthy individuals. So I don't think you have to be a statistician to see that that's probably not all that different from zero, right? This is 3 months after the injury. Neuropsychologically, there's really not a difference between people who have had a concussion and those who haven't. Look to one column to the left, trauma controls. That refers to studies involving orthopedic trauma, but no brain injury. And you'll see that the effect size for that group is actually a lot larger than it is for the mild TBI group 3 months after the injury. So then you keep panning to the left, you'll see all these other groups have far larger effect sizes on neuropsychological testing than do people with mild TBI / concussion 3 months after the injury. Now, if you did this study 3 days after the injury, you'd have a larger effect size in this mild TBI group. But the take-home message for me is that 3 months later, there really isn't a difference between those who have had one and those who haven't. Okay, next slide. More diagnostic challenges here. This is with regard to PTSD. Now, PTSD can look like TBI in a lot of ways. And though this is not on this slide, but PTSD criteria were changed a little bit for the DSM-5. And shortly after they came out, a group published a study showing that the new criteria led to 636,000 different ways to meet criteria for this one condition. So immediately, again, I don't think you have to be a psychiatrist, neuropsychologist, neurologist to realize that might not be all that helpful. It's very, very amorphous, a lot of heterogeneity in this thing called PTSD. Unfortunately, it is the thing that can look like concussion too. And even more unfortunately, we're often asked to disentangle these conditions. But there's lots and lots of ways you can meet criteria for this PTSD thing. Exaggeration also can be actually a genuine component of PTSD. It's not unusual to see somebody with PTSD who exaggerates as a part of that condition. There's a hyperreactivity that's kind of a part of the condition. So we have to take that into account before we attribute the exaggeration to something else. Yes, Nathan.
I just want to comment on this. There's a great book by Simon. It's a bit older, on forensic aspects of PTSD. And he talks about PTSD being the most frequently malingered psychiatric diagnosis in the context of litigation, just as an FYI.
Absolutely. There's a lot to be said about PTSD. And I know we're talking about brain injury mostly, but there's issues with just the first criterion of PTA, the first criterion in the DSM-5 about whether or not people meet that criterion. Oftentimes it's not really discussed in the records as much as I think is necessary.
Right. But it is still important because we often see it as a dual diagnosis along with PTSD, particularly in individuals who don't have significant amnesia associated with their injury, where the risk is higher. If you're amnestic, it tends to be protective.
Absolutely. Yep. That's a very good point. The reliability of the client or the patient is a big deal here too. It's also a very big deal with regard to concussion, but also with PTSD. Their recall can be distorted for a number of reasons, and often there's no way to get good objective evidence, or at least another set of eyes on the issue at the time, because there's no one else there. Again, PTSD symptoms are non-specific. I think we've talked about that enough. We can do next slide, please. So what are some of the forensic influences? So we know that forensic contexts do confer different risks to individuals than in the clinical environment. And there's a lot of possible reasons for that. Just a handful here. The expectations, again, this idea that if you're led to believe that you have a permanent brain injury, the odds are pretty good that you're going to start to live your life that way, believing that you do have that. There's the idea of justice, or trying to get justice through the legal system, and what that might do to your behavior and your beliefs. And the idea that an injustice has been done to you. The cry for help idea, which has been around for a long, long time. Just being angry about what happened, rehearsing your symptoms, which is a very common part of the litigation process. Taking on an identity of having TBI, which again is related to this expectation thing. And like Dr. Zasler mentioned, there's this nocebo and iatrogenesis thing that happens in litigation as well. Unfortunately, the outcomes in this population tend to be worse in litigants, no matter how it works out legally for them. Probably because it's a stressful time, but it could be because maybe this is a group of people that are more injured than people who don't litigate. It's not clear why, but the outcomes do tend to be not as good. So this is low-hanging fruit here, but it must be the lawyer's fault that they're doing poorly.
I'm surprised they got through the screeners, Dr. Bender.
Yes, I snuck it in at the end. Next slide, please. All right, just a little bit more on self-report of symptoms and whether or not it's even reasonable to expect the client or patient to be an accurate reporter. I don't think it is, frankly, to no fault of their own necessarily. But there's a good study came out a while ago now with regard to car accidents in particular, that half of patients who had pain before, documented in their records as having had pain before the accident, denied having it after the accident. And other things too that, again, reflect some sort of impression management, where they're trying to look a certain way, where they would deny taking part in things that they thought might not make them look good after this accident. Good old days bias is another one of these things that affects your self-report. It's the idea that whatever is happening now is worse than it was before. You tend to overstate how good things were before the accident and understate how good they are now. It's a well-known phenomenon, been around for a while. Diagnosis threat, this came up a minute ago too, I think, as the idea of being labeled with a certain thing can affect outcome. There was a small study done, it's been a while now, comparing people who were labeled traumatic brain injury and another group labeled concussion. They had the same degree of injury, but only called different things. Outcomes were better in the concussion group. And then there's misattribution, the idea that every symptom that you have now can only be attributable to the accident. These are common cognitive biases. These are not unusual, and it doesn't mean that there's something wrong with the person. This is not necessarily a pathology. They can be clinically sort of pathological if they get to a certain level, I believe at least. But these are very common in the healthy, population. So next slide. More problems here. I know this is painting a grim picture, but there are things that we can do about these things, and I'll get there, I promise.
Scott, if I may,
Sure.
there's also additional literature, Paul Lees Haley and others, looking at accuracy of brain injury survivors reporting relative to reporting from families. And there's often a significant disparity, which kind of really emphasizes the need to do corroboratory interviews, both in clinical and forensic contexts.
Absolutely. You'd be surprised. And yeah, they can actually be used. They can be helpful too in seeing if the family is on board with any deception that might be going on.
Right.
And oftentimes that's easier to detect because now you've got a lot of moving parts and they've got to stay on the same page, and you can ask questions that can kind of disentangle that. All right. So at the end of the day, though, we're still not able to directly know or assess even one's intentions. There's smoking guns, but motivations really are inherent to a person, and we don't have a way of doing that. And I'll get to that in a minute about why that's so important with regard to the definition of malingering. Nathan, were you going to say something?
No, I'm good.
Okay. The things that can look like malingering are significant here. There's a number of them, and we've talked about most of these already. But the important thing to remember from this slide is that we're not just talking about one thing that we're comparing to, and if we rule that out, well, then we know it's genuine or we know it's feigned. There's a number of steps to this process. Okay, next slide. All right, we've talked a little bit about this too, that the symptoms of TBI are particularly easy to feign, certainly with regard to concussion. Because of that, it's important to use multiple strategies. Now, if we had talked about this 25 years ago or so, there really weren't a lot of strategies. In fact, way back in the 80s, most physicians and neuropsychologists would just say, well, no, I just know. I just know when they're feigning. I don't need a test. Well, that whole idea was exploded in the 80s and 90s when studies started showing that, no, there really is a way to do this. And then empirical methods, statistically based normative studies and tests are way better than just clinical judgment. We can go to the next slide.
If I may add, clinical judgment has been studied relative to empirical methods and shown to be extremely poor in terms of accuracy.
Yeah, which is sort of humbling, I think, for us, but important to remember. So here's
when a doctor says, oh, in my experience, and hasn't done anything with any evidence-based technique to assess validity, that's pretty much garbage in a courtroom as far as I'm concerned.
Yeah. So I think we'll call him Richard. This guy, Richard, was referred for a neuropsychological evaluation 2.5 years after the accident. And at that time, he had multiple deficits in neurocognitive functioning. His speech was described as halting, and which was new, and again, another symptom that had emerged later. And when I reviewed the raw data, there was evidence of poor effort, in a number of ways that were evident during the testing, but they weren't mentioned in the report for some reason. He was diagnosed with post-concussive syndrome. At that point, experts were retained and the deposition started about that time. So next slide, and we'll come back to that again. What about moderate to severe TBI? Well, effort can be poor in these groups too, but sometimes it's not due to intentionally reducing effort. In fact, it tends to be far less likely in this group than in the concussion group. There can be a reduction in what's called conation, or a reduction in insight or relevance. Conation is basically the will to engage in a cognitive endeavor, something that we often take for granted, but it can be impaired, and especially in these more significant TBI levels. And really profound levels of impairment can reduce your performance on these tests that are really good otherwise at detecting poor effort. These groups are different though, and we have to interpret them differently than we do in concussion. There are a couple of cases of unequivocal malingering in severe TBI, so it should be noted that that can happen. Next slide, please. So this has turned out, I've had this slide in my deck for years and years, and it's become sort of almost an age test for people who recognize this versus those who don't. This is Klinger from the show MASH, who was always trying to get out. He was malingering basically the whole time to try to get out of the military. Next slide. So the most common definition of malingering is the one that you'll find in the DSM-5. It hasn't changed much over the iterations of the DSM. It is a V code. And what that means is it's not a diagnosis, right? There's no disorder here. So technically you wouldn't diagnose it, though we do consider it that way because there are criteria for it. So we end up saying diagnosis, but it isn't a disorder. It's a classification of behavior. And I think you're going to have to move to the next slide to activate the next line. Yeah. And it's defined as the intentional production of false or grossly exaggerated symptoms motivated by external incentives. Now that's, I think, a very pithy and helpful definition, certainly on the surface. It does designate this issue of intentionality. You've got to be doing it on purpose, in other words. And it's got to be motivated by external things, not some internal thing where you want to be seen as sick for your own reasons that don't have anything to do with avoiding prosecution or getting money or something like that, which is its own thing. That's a factitious disorder, and that is considered a mental disorder. That's not malingering, right? That's different. The definition differentiates those well. I think that does a good job of that. What it doesn't do, and I don't think it can do, is really get at this motivation issue. We're again relying on motivated by external incentives. And what ends up happening is that we equate the presence of incentives with the motivation to engage in the behavior. And unfortunately, there's not really a way around that. We inform that equivalency with testing and direct observation and surveillance and all sorts of things that can be very powerful and compelling, but they're not the same as that. So that's one of the limits. And I know Nathan mentioned earlier that there's a reticence to call malingering. And I think this is one of the reasons for that. Next slide, please. Yeah, the other parts of that last slide were just reasons that you might engage in malingering. So this is a good slide, I think, because it shows that there are criteria for evaluating malingered neuropsychological dysfunction specifically. The DSM-5 is not helpful for this particular area. So the first version of this criteria was published a long time ago now, and then it was revised in 2013, and then again, just a couple of years ago. And I think the revisions have been very helpful. Unfortunately, there hasn't been a lot of validation study on these criteria. I think some of that is logistic. I think it's going to be very challenging to do it, but it needs to be done. But I think there are strong merits to the new criteria. There's some specifics here about PVT failure. These are, performance validity failures. There's formulas for this now. How many is too many? How many, what's the numerator? What's the denominator? Things like that. We're still stuck though with this problem of not knowing with absolute certainty what the motivation was. So if someone fails these things, even fails them badly, you can say that there are performances that I can say confidently that I know they failed this test on purpose. And statistically, I can put a number on that. But that's not the same thing as saying I know that they did it on purpose because they're trying to get money. There's another step involved, and that is a clinical determination at the end of the day. Next slide. Here are some of the things that can look like malingering. Somatic symptom disorder, what we used to call somatization disorder. And that's, in essence, excess anxiety about your physical health that can manifest in a number of ways. It's often complaints of pain, but the core feature is that the amount of distress and anxiety being caused by this thing is disproportionate to the injury or the cause itself. I believe that this is very common in the concussion group, and that those who have protracted recoveries often will have features, if not the full-blown condition, will have features of this condition, complicated by these other things that we've talked about, these biases that start to emerge, particularly in litigation.
Scott, if I
Sure.
may, if you can wrap, because we're approaching 10 minutes.
Oh, is that right? All right, sorry about that. Sure, so we'll move through. Next slide, please. So PBT tests, our tests, I think this is an important slide because these are the tests that were developed expressly to detect exaggeration or insufficient effort during testing. The way these are constructed is that these tests are given to populations of patients who have severe impairment, yet do fine on these tests. So if someone does really poorly on this test, it really does limit the number of explanations there could be for that. So the primary is, well, they're just not trying. So this is part of the formula for figuring out if someone is demonstrating a profile that is invalid or non-credible. SVTs are generally the same thing. They're constructed a little bit differently, but they do the same thing, except with regard to psychiatric symptoms, not cognitive symptoms. Next slide, please. So should this be the last slide, or we'd have a couple minutes still?
Go ahead.
Go, just with this slide, or keep going?
No, couple minutes.
Okay, good. So just to wrap up with that, what happened with Richard here, I did an IME on the gentleman 3.5 years after the accident. There was clear exaggeration and cognitive effort wasn't great, but I didn't feel that it rose to the level of frank fabrication and malingering. His pain persisted, but had improved, whether he was on medicine or not by this point. I didn't find any evidence of PTSD, though there had been claims of that prior. I didn't find any evidence of a neurocognitive disorder of any kind, including with regard to concussion. And I did feel like these things that we've been talking about really played a strong role in this gentleman's life in the setting of litigation. And at the end of all this, it did settle. Next slide. Now, this is a slide, and Nathan, you can maybe address some of this. He spearheaded a paper on these issues that he mentioned a little bit ago in his portion of the talk, how there's been a lot of changes that are emerging out of the plaintiff bar that are limiting what an IME can be. And it's really difficult. As a neuropsychologist, one of the primary things that is happening is that they're requiring that the raw data we have from our testing be turned over to the attorneys themselves. Ethically, that's a problem. We have position papers on that and ethical issues because we're putting that data in the hands of somebody who doesn't necessarily understand it, increasing the risk of misuse, mischaracterization, misunderstanding of this data, where the easy solution that we've been using all along in the past is just to have that data turned over to a psychologist or neuropsychologist that they retain and can explain to them. There's a number of other things that are being done as well, including this third-party observer, where they want someone to observe what's going on during the exam. And there are data, there is research showing that by itself can impact the person's responses and their willingness to engage in the interview. It certainly can affect rapport during the exam.
And performance on testing.
Right, and there's a long history of research showing that that happens too. And that, at the end of the day, that can actually hurt the client, because now you can't use the data, or it might be mischaracterized in the way that they're not getting useful information from the exam. It's wasted their time.
I would just add, Scott, that I've been told how long I can take on the exam, what tests I can give or can't give. I've been asked, what tests are you going to give, which is just ridiculous. I've been told, again, that there needed to be videotaping or audio taping or a nurse case manager sitting in the context of the IME. So there's all these kind of things that are delineated in the paper. The paper was ultimately signed off by probably 23 experts in the Commonwealth who are involved with this type of work, both physicians and neuropsychologists. So there was clear consensus, even among people who are often opposite each other on defense versus plaintiff sides, about the importance of these issues not becoming commonplace, but clearly they're being pushed by the plaintiff bar. And I see plaintiff patients all the time because I'm a clinician. So most of the patients I see, I'm involved with their attorneys. But in the context of defense exam, this has become quite problematic.
Yep. Yeah.
Let me jump in and maybe we can roll over to questions to the extent the audience has any questions in the remaining 8 or so minutes, Dr. Bender and Dr. Zasler. One question that I did have, you both mentioned it, this concept of onset of symptoms. And I'm curious from your perspective whether there is any consensus in the medical literature when the onset of symptoms begins too far past the injury date such that a true brain injury is unlikely, and recognizing that the members in the audience as adjusters, their job is to identify those true brain injuries so that they can get good active treatment from those that are phony and false. But what are your comments about the onset of symptoms and the delay?
Scott, can I take that first?
Sure.
Okay. So I think it depends what symptom, because different symptoms may have different onset. So for example, headache, which in my practice, I would tell you that most headache doesn't have to do with the brain injury, but has to do with associated whiplash injury. Typically has onset within 24 to 48 hours. That doesn't mean you can't develop headache after that, but commonly it's fairly acute. Cognitive issues are worst up front, tend to get better with time. Sometimes people who are held out of work, told to get bed rest, not do anything, and don't go back to work are not cognitively challenged, so they don't necessarily tap their cognitive deficits until they're back in a more demanding environment. And you might see an increase at that point. But generally, in terms of what's actually happening, the load is highest early and gets less with time. Different impairments tend to have different onset. So smell loss, for example, that would be immediate. Tinnitus, if it's injury related, that would be immediate. So again, there's a whole litany of impairments that you could talk about. Fatigue might be delayed because you have chronic pain issues and you develop sleep disruption, and then you develop fatigue consequentially. Depression might be delayed and still related to the injury because you develop chronic pain, thinking problems, they're not getting better, and then you become depressed or anxious about it. Scott, you want to add?
Yeah, that the timing is very important to figure that out. Like you said, Nathan, that it has a lot to do with what symptom you're talking about. That predicts what would be unusual in terms of the timing. But it's also just the symptom by itself, regardless of the timing. I mean, like if somebody starts, let's say 3 months, 6 months after starts to have a tic, that's not the brain injury. So there's certain symptoms that no matter when you see them are just not characteristic of concussion, and actually are characteristic of something else. Those are strong indicators of some, maybe a psychogenic evolution.
The other point, Scott, if I may, attorney,
Yep.
Sorry, there's two Scotts. I got to be careful there. The other point that you made that sort of rung a bell with me was getting people into appropriate treatment. And again, I think one of the challenges is there's not that many people who really know this stuff well. I'm not saying Dr. Bender and I are the only ones to refer to, but this is a fairly narrow field of expertise within the Commonwealth of Virginia. and getting your patients or claimants to people who know what they're doing as opposed to don't know what they're doing is really critical in facilitating faster return to work, better outcomes, and overall recovery. I see tons of patients who come to me with headache as an example. When I start to examine them and ask them to lay down and I start palpating their head, their neck, their shoulders, which is just part of a good headache exam after a trauma injury, they go, "What are you doing?" And I say, "Well, I'm examining you." And they say, "Well, no one's ever done that before. And I've seen 4 different doctors before I saw you because my work comp people said enough, go to Zasler." That's a shame, but that's the reality of medical practice that's driven by cost constraints, time constraints. People don't take the time to adequately assess these folks, and they are often complex, as I hope we've conveyed today.
Let me ask one more question. We may be out of time, but again, as I indicated, many in the audience, we have a lot of nurses and we have a lot of adjusters, but one of the key roles for the adjusters is to identify, whether they're dealing with a legitimate claim or not. Are there any tips from the physician perspective that you would offer the adjuster when they have that claim that they think it doesn't look like it's a true brain injury? Any questions that you would recommend that they absolutely ask in that recorded statement? Because of course, they're the ones that generally make first contact with the injured workers. And I find from a defense perspective, that information that they glean is often the most reliable information.
Right. Well, you covered a lot of it in your red flags slide, as did I, and I think Scott alluded to some of them as well. I would also offer, if I may, and I won't speak for Dr. Bender, but if adjusters have cases that they want to run by in just a short phone conversation or an email, I'm happy to take those calls and try to be of help. But I think it's complex, and I wouldn't expect an adjuster to be a clinician, just like I wouldn't be expected to be an adjuster. So again, I think that's why people like us are hopefully out there to be of assistance in dealing with those kinds of more complex cases where there's lack of clarity as to what exactly was going on or not going on. So I'd go back to those slides as far as what the red flags are. Did you lose consciousness? Were you dazed? Were you confused? Do you remember the accident? The less loss of consciousness, the more memory, the less dazing, the less confusion, the less likely it is they have an injury that's going to produce any type of protracted symptomatology.
Okay, and we're running out of time, but I'd like Ross to share your contact information. It was at the end of the slide.
Were there more questions, Attorney Ford?
Let's see. I think somebody said, but they can't get you on the phone. So maybe Dr. Zasler, you could do a private Zoom call with the adjuster while they're taking a recorded statement. But I think that was just in jest there. One person did ask, what is focal neurologic deficits?
Focal neurologic deficit just means a localized neurologic abnormality, like, for example, a weakness in one limb would be a focal neurologic deficit. A ptosis of the eye would be a focal neurologic deficit. A tic would be a focal neurologic deficit.
All right. And I have one last question. I think we'll be out of time. But Dr. Bender, I know you are doing these all the time, but the adjusters in the audience are familiar with seeing the paper and pencil tests that come across in the files when there's neuropsychological testing. Number one, are those reliable? Number two, can they be gamed or tricked by the participant? And I guess number three, what tips would you have for the adjuster on when reviewing those, what to look for?
Well, with regard to the first question, it depends on what tests you're giving and how they're used. Unfortunately, there's no great answer for that. If the right tests are used, yes, there's a lot of research supporting the best tests out there. There's no reason to not give them. They're reliable, they're valid, and they do a good job of determining whether or not even subtle deficits exist. The appropriate comprehensive exam would also be able to rule out the things that look like concussion, rule in or out malingering. at least to the extent that we can do that. The state of the art, state of the science is there, and you can use those tests. I don't know if that answers your question. What was the last of the three?
Just when they're reviewing them, what they should be looking for.
You should be looking for, this might, again, kind of what Dr. Zasler was saying, might be too much to ask because it's a lot of moving parts, but I would be looking for indications that some differential diagnostic process took place, that they just didn't.
Morally lacking most of the time.
Usually it's just this person came to me and told me they think they have a concussion. Then you read through 3 or 4 pages and they say concussion. And there's really no background history. There's no integration of all these other sources of data, and there's no differential diagnosis. There's no thinking and consideration of these other things that could cause symptoms that look like concussion. So I'd be looking for that in the report.
And they may be real and trauma related issues. It doesn't necessarily mean they're not injury related,
Right.
which is possible. But I see that all the time where there's way over apportionment. Every symptom that the patient presents with, because they had a history of concussion, is post-concussive. That's just nonsense.
Right.
Well, thank you both. I think we're out of time at this point, but I want to thank both Drs. Bender and Zasler. Obviously, this is a very complex topic, very important in the work comp industry, and I thank you both. It's wonderful having excellent experts available. I also want to thank the folks on the back end, Ross, John, and Kimberly in my office for putting this together seamlessly. And of course, thank the participants. We had 202 register and a good amount that appeared today. If you want the presentation, it is going to be made available. Just reach out to my office. If you have any questions, you've got the contact information for both Drs. Bender and Dr. Zasler. And if, of course, we can help you from a legal perspective, feel free to reach out to my team here in Richmond or Roanoke or Fairfax or Virginia Beach. Happy to help you. I also want to mention we do have our annual seminar. I think we're at 21 or 22 years at this point. I can't recall which one. I think John probably will tell me, but that will be September the 15th. We've got a great lineup this year and very excited for that. It'll be at the Westin here in Richmond, Virginia. There's a cocktail reception that precedes it the evening before. So if you've not signed up, please sign up. But thank you, everybody, again, for participating today. This has been wonderful. Thank you, everybody.
Thank you for inviting us.
Yeah, thank you
Yes,
very
sir.
much.
Always a pleasure.
Thank you both.
Bye.